So good evening all. So we will start a session on MSK. So today we will do one history and one clinical and one communication and one video. Okay. So as of now, I think we have some 40 members in the group. And can I just put in the chat box who wants to try the history? We have one history, one clinical, and one communication, one video. And history, we will do only the initial 9 plus 4 minutes. We will not go into the discussion for the sake of time convenience. So just keep typing in the chat box. If somebody is willing to volunteer to do the question. And please name yourself, doctor. Just kindly mute yourself. Others, please mute yourself. There's a lot of background noise. Hello.
Am I audible?
Yeah, you are audible, but there is a lot of background noise. Yes, now it's better. Okay. So who wants to do the history one? Before that, we are starting our diet for the our sessions for 3-month sessions for the next diet. So who is willing can communicate one of us. We have a number of 4 and we give classes over Zoom. Okay. So I'll give us contact numbers at the end of the Balaji and Dr. Hashra. You can contact them for joining our group. So anybody volunteering for the history session? Please post your name in the chat box. We can start the history. So we will give all the details of our session. You can contact one of us. We will give the contact number at the end of the session. So Dr. Shaheen, can you open your mic and video if you want? You can open, or if you want to be without video, you can do without video.
Can you give me a 2 minutes, sir?
Yes, Dr. Your name? You want to do history?
Yes. Okay.
Okay, Real Medico wants to do communication. Please name yourself, Doctor. Dr. Tanushree
myself,
wants to
Dr.
do clinical. Okay.
Sir, my name is Priya and I want to do communication.
Your audio is not clear, Doctor.
So Priya want to do communication.
Sir, have you shared the scenario?
And let me share the scenario. So who wants to do history?
Me, doctor.
Can you open your
Yes, Dr. Shaheen here.
Dr. Dakshan? Okay, sir. So you want to have the video on or off, sir?
Off.
Off. Okay, sir.
Hello, myself, Dr.
Yes,
Shall
doctor,
I
you can
start,
start.
sir?
Yeah.
Hello, myself Dr. Shine. I'm one of the registrar working here in this hospital. Am I speaking to Mrs. Annie, mother of 4-year-old girl Rachel?
Yes, doctor. Good evening. You can call me Annie.
Good evening. Nice to meet you, Mrs. Annie. So today I'm here to explore about the Rachel's head condition. So is it the right time to talk to you?
Yeah, yes, doctor.
Okay. Mrs. Annie, while discussing, I would like to take few notes if you don't mind.
Yeah, sure, doctor. No issues.
Okay, thank you so much. Annie, can you tell me in your own words that what has happened to the Rachel, which is bothering to you so much, and you are coming here today?
Yeah, yes, doctor. Actually, Rachel, my child, she is 4 years, doctor. And she is having this joint pain for the last 3 months, I would say. And it was,
Mm-hmm.
actually, it started was like um, mild to moderate pain, I would say, because she was actually playing that. She had some discomfort over her foot while she is playing and running. But then he did not restrict her activity. But I would say that now this is increasing. And initially, the GP gave me some medicines, paracetamol and some pain medicine, Brufen as well. And there was some response, although it was not total, I would say. But now it is increasing, doctor. So I asked the GP to give a referral to meet you. Actually, I was waiting to meet you for the last 2 weeks or so.
I can understand, Mrs. Annie. This must be a very difficult time for you. And thank you for waiting for so much long time. Is this all started just before 3 months, or it's before that? Uh, Hello.
Actually, it is only 3 months, doctor. I would say 3, 4 months maximum.
Okay. And I can see from my notes that you are visiting thrice at the OPD clinic. So can you please tell me in detail, like why you are visiting for that OPD?
Yeah, yeah, sure. So, like, one thing is we went for the joint pain. As I told you, I actually had pain over her right foot, and then
Mm-hmm.
we went for that once. And then
Okay.
she had a fall like 2, 3 times when she is playing, like she fell down. So we went for that, and she had some minor trauma because of that. So we went for
Mm-hmm.
that also.
Okay. Uh, is this the joint pain? All of a sudden, like, have you noticed any redness or any warmness around his joint along with this pain?
No, but I don't notice any redness. Not sure whether she had any one, but definitely no redness.
No redness. Okay. Does and where is the exactly this joint pain happens? Is it in the knee? Is it in the ankle, or at a multiple place?
No, doctor. Initially, as I told you, it was the right foot actually. I would say exactly at the level of this ankle, and it was a bit swollen also initially. Then the GP gave me this paracetamol initially, and then they gave this pain medicine, Brufen also. I think it was Brufen only, and then it
Mm-hmm.
got subsided. But again, last month she had this pain over the right knee as well. So I'm a
Okay.
bit bothered about now.
Oh, yes, yes, I can understand from your shoes that this must be a very difficult. So I want to ask you, is this pain associated with any fever in this during these periods?
No fever, doctor.
Okay. And have you noticed any rash on her bodies?
No, I didn't notice any rash.
Okay. So in during these 3 months, the right ankle has swollen, which is subside, and again last 1 month you notice the swelling is on at the right knee. Am I correct?
Yeah, yes, doctor.
Okay. Have you noticed any? Does she looks pale to you?
No, doctor, I don't think she is pale. But I'm not sure, doctor, because she is also like she fell down twice or thrice. Uh, uh,
Mm-hmm.
I'm not sure whether she is really weak because I think you are asking whether she is having low blood. I do have a doubt
Yes.
with that doctor. Can you please give me the test also? Because I'm not sure that she is generally weak.
Yes, definitely. We will look into that matter once we finish discussing these things. And have you noticed any lumps and bumps in her bodies? Any small lumps in her neck area or anything anywhere else?
No, doctor, it's something like that.
Okay. Any tummy swelling or any other swelling in her body?
No, I don't think she went swelling or swelling anywhere.
Okay. At any point, any given point of time, is she complain any chest pain or any heart racing?
No, doctor, like I don't think she can complain chest pain, but I don't think her heart is racing. She's otherwise playing, doctor. Even this after this pain, when the medicine was given, she's playing well and she's otherwise active. I don't think her heart
Okay,
is
all
racing.
right. Okay, all right. Good to hear that. And have you noticed any weakness in her body? Like frequently, while walking, she was used to falling, or any headache?
Yes, so I'm not sure whether she's having headache. I don't think she can comment on headache. She's just 4 years better. And I'm not sure that she is weak also, but I have doubt whether she doesn't seem to feel something better. Like she falls frequently, like last 3 times. One time she was
Sorry.
playing in her play school, and then she fell down without noticing the obstacle in front of her. And then once she fell down in the park. Uh, uh, I'm not sure because I'm
Mm-hmm.
not sure that she is really watching itself or not. I'm not sure that.
Okay. So when she was like falling in the
Also, I'm
park,
not
does
sure
she
whether
lose
it
her
is.
conscious?
I'm sorry to interrupt, doctor.
Mm-hmm.
I'm not sure whether it is quite
No, no,
okay
it's
at
okay.
this age to fall down because children. I understand that they are quite playful.
Mm-hmm.
So I'm not sure whether that's relevant at all. I'm not sure.
Okay, all right, Mrs. Anita, it's all right. As you mentioned that she is falling on the park, so did she lose consciousness at that time?
No, doctor. No.
Okay, all right. Have you noticed any changes in her pee and poo? Any color
No, doctor.
changes?
I don't think
No?
so. No color change.
Okay. Has she noticed any tummy pain or anything like that?
No, doctor. She is not something like that. She is otherwise checking her
Okay.
feet stuff.
Uh, okay, all right. Do you have any concern regarding her hearing and vision?
Hearing, I don't think that she is playing well. At times she sings some rhymes also. She
Mm-hmm.
gets to know that from her play school. I don't think she has an hearing issue.
Mm-hmm.
Vision, as I said, I'm not sure whether she has any problem with her eye because sometimes she doesn't notice the things around and she falls down. I'm not sure, doctor, whether she has a problem with vision. I would be happy if you could test that her eyes also.
Sorry, can you repeat, please? There is a
Yeah, I'm not
network
sure
issue.
about whether she has a problem with her vision because she fails on frequently. I'm not. I just want to get a referral from you for testing her eye also, if that's possible.
Oh, yes, Mrs. Anita. As I mentioned you that after taking the detailed history and all the things, then I will definitely refer you to the eye doctor. Okay, don't worry. She's 4 year old now. So how many times she was admitted before? Is there any significant hospital admission in the past?
No, doctor, no, she was not admitted, but just we went to the GP for this fall twice and for this
Mm-hmm.
joint pain twice.
Okay. And GP just prescribe you some painkiller medication. Is there any test was done?
No, doctor, no test was done.
Okay. And
He told that you
uh,
you will give us a test because this is happening for the second time. So I came to you.
yeah, I can understand, Mrs. Anita. This must be a very stressful time for you to seeing your child in this situation. I will definitely help you. So can you describe her birth event for me?
She's more normal, doctor. She is born at I think around 9 months, and 9 months
Mhm.
old, and her weight
Okay.
was 3.5,
Okay.
and everything was fine. I don't have any issues
That
during her birth.
okay. Uh, okay. Does she require any hospital admission at the time of birth in the NICU admission?
No, doctor. Like she was fine.
No.
She cried well, and
Okay.
I fed her
Okay.
immediately. Everything was fine.
Mhm. Okay. And how was your health at a time while you are pregnant with her? Do you have any diabetes, any thyroid issues?
No, doctor. I'm perfectly fine. I did not have any
Okay.
issues.
On. Okay. So, do you have any concern regarding her growth and development?
No, doctor. I think she sometimes she is a picky eater, I would say. Otherwise,
Mm-hmm.
I'm not having any issues with that. And I think the GP told me that her growth intakes are fairly okay. Um, I don't have an issue with that.
Okay. So, what she prefers to eat? Like you said, it's a picky eater. So, what she prefers to eat?
That's very hard to say, doctor. Like she has her own favorite things each time. Sometimes she likes to have some big bread, and sometimes she likes to have only fruits for the breakfast. It's bit
Mm-hmm.
variable, but the GP, I did raise this issue with the GP, and he told me that it's quite normal for children at this age to be um, quite picky,
Oh,
and it will change with time.
okay. Okay, Mrs. Anita. Mrs. Anita, can you describe your family for me? How many members are there in your family?
Uh, yes, doctor. Like, we are member of four, and my husband is a school teacher. I'm a homemaker, and I have one elder boy. He's 7 years.
Mhm. So, is there any other family member having a similar kind of joint pain or any other illness in the family?
No joint pain, doctor. My husband has some skin problems, but he doesn't have a joint pain.
Sorry, husband has what?
He has some skin issues, and he is following with the skin doctor for his skin problem.
Okay, all right. How is he doing now, right now? Is he all right?
Yeah, he is fine. He
Okay.
takes some ointments,
Uh,
and he visits the skin doctor like once in 3 months or so.
Okay. And what do you do for living?
Yeah, my husband, as I told you, doctor, my husband is a school teacher, and I'm a homemaker. So that's okay.
Sir, I couldn't hear. I couldn't hear your voice. There is so much echoing.
Yes. Others,
Hello.
kindly mute yourself, please. So my husband is a
Husband.
school teacher, doctor, and I'm a
Good
homemaker.
teacher. Okay. Okay. And does your family income satisfied for you?
Yes, doctor, we don't have any issues with that.
Okay. Okay. So, and who takes care of your child? Like you yourself take care both of your child?
Yeah, yes, doctor. I'm staying home, and I obviously take care of my children, and I'm quite happy to do that.
Okay. Mm-hmm. So, I want to ask you that she is having Rachel, am I right? So, Rachel is
Yeah.
having a pain since last 3 months. So, how was this condition impact her?
Um, she is not able to play with her other physical peers. That is one thing. And
Mm-hmm.
apart from that, but this is improving with this pain medicine. But in between, it's coming back again. So that's the point of worry to me. And as well as she is having this frequent falls,
Mm-hmm.
and it's worried.
Okay. And how does this affect your family health overall?
Like my husband is also bit worried, doctor. So he actually pressed the GP for a referral. Uh, So like otherwise, like we are actually waiting to do some tests and to make sure that this we are not missing something serious because this has been going on for the last 3 months.
No. Oh, yes, yes. Okay. I can understand from your shoes. This must be a very difficult time for you. I'm sorry to ask you, but by any chance, your family known to any social service?
No, doctor, you don't have any requirement or need for that. Okay, fine.
Mhm.
Okay, doctor. Okay, just time is up now. Okay, so give a quick summary of your history.
Okay, so today I've taken history from Mrs. Anita, who is a mother of 4-year-old lovely girl Rachel, who is coming with complaint of joint pain and frequent fall while in the past. Right now, this joint pain is not associated with any fever, rash, and any pallor, any lumps and bumps, any tummy swelling, any heart racing, or any vision or hearing issues. There is the on a background history of she is having a frequent fall for which she was getting OPD treatment with a GP 3 times, and GP was given some painkiller medication, and the pain was relieved. There was no investigation was done at that time. Before the knee swelling, which is the whole thing started with a ankle swelling, which was around, but it was resolved by giving a medication. And last 1 month, again she's noticed that she having a right knee swelling and pain since last 1 month. Uh, the birth history was not that significant. Developmentally, the mother has no issues at all. And nutritional history wise, she was a picky eater. She used to like to take some fruits and vegetables. There is no concern regarding her family. There was the family is known to any social services, and mother socially the mother is under stress because of this frequent fall of her child, and there is that because of this joint swelling and pain.
Okay, doctor. So, can you give your differentials from your
So
from whatever history you have taken? What are your thoughts?
my first differential diagnosis, as this joint pain is started long ago, so it could means 3 months ago, and first it ankle and right ankle joint are swelling, then right knee joints are swelling. So it might be a case of oligoarticular juvenile idiopathic arthritis. Second could be due to frequent fall, or this time might be she fall. It could be a septic arthritis, or though there is no history of fever, I get there is no redness or hotness around the joint as a signs of inflammation. Third could be reactive arthritis, but there is no past history of any upper respiratory tract infection or genitourinary tract infection. The fourth differential could be non-accidental injuries, but there is no families are not known to social service, and mother take care by herself to the child, and there is no nothing significant I could ascertain along with NI.
Okay, doctor. Thank you. Okay, others, we can have a quick feedback here.
Yes, I would like to comment. Can I?
Yeah, I know your name, doctor.
Yeah, my name is Dr. Ikra. So, in her history, it was not in a systematic way, in a sense that when you asked about the joint pains, first ankle swelling, and then followed by knee joint pain as well as swelling for the past 3 to 1 months. Like initially, it was 1 month and then 3 months. So how did it progress? Like, how was the mobility of the child? How was the walking like? What were the was there any walking support required or not? And then vision association, it could have gone with this oligo-articular. So what did they do about that? In UK, do they perform this preschool vision assessment or not? So this thing was there, and preceding URTI history was important to rule out the this rheumatic thing. Okay. And then SLE could have been there, though it is very less likely in children of 4 years of age. But she asked about the rashes, but sun hypersensitivity could have been asked. Okay. And then malignancy, yeah, she asked about this thing that lumps and
Weight
bumps.
loss,
Okay,
pallor.
yeah, but that was given in the comment as well, in the opening notes, that the growth centiles were normal, almost normal. So bony night pains could have been asked over there. Okay, and then NAI, if you want to rule it out specifically, you have to ask about the bruises. It does not come under this. Bluish spots could have been asked or something like that. It needs a bit more explanation if you are including it in this differential. Malignancy was important. Then IBDs, you said no tummy pains or something, and chronic eating problems were not there. Okay, and nail changes could be asked in this thing, rheumatological problems. Okay, and then growth parameters are fine, and yeah, so these were the points. Early morning stiffness was also very important to be specifically asked if you are including oligoarticular, and this pain relieves the rest, so that question should be specifically asked. Okay, done. Thank you.
Yes, thank you for the feedback. Any others want to add any doubts, any more questions in the history, or you want to add some points?
Sir, whenever we
I
get any history, like any history, so we can make a general performer, like we can, what we need to ask in chief complaints, like odds para, and then mnemonics for systemic screening. We have to write DDs also, like in this case, like he's having joint pain for the past 3 months. So our DDs should be like pertaining to joint. So it could be JIA, SLE, or cancer related leukemia, or orthopedic related problem, osteosarcoma, or migratory arthritis he has. So we can keep even rheumatoid arthritis, like RHD, NAI. Other than that, so what should be all included in DDs?
Okay, I come to that. Okay. So, others, any comments, any questions or comments, or any other things you want to ask in the history?
Yes, sir. One more. I think
Yeah.
he kept saying Anita, whereas this is Annie. I don't think
Yes.
that mistake is taken lightly by the examiners.
Okay. Point
Thank
noted.
you so
Yes.
much.
Yeah, yes. I think she did well. I think she uh, not that systemic. She was quite systematic. I have a few things that I would like to think again, like when mother had a concern about frequent fall related to her vision. So that area should be probed a bit more, because whether any assessment was done, because maybe it is related to uveitis or something which may be associated with the oligoarticular, that will point towards our main DD like JIA, oligoarticular JIA. And second thing that should also be probed about father's skin lesion, whether it was any diagnosis was given to father like psoriatic. That may also be included as a DD. Otherwise, he needs to have pro forma like Odis para, and then diagnosis, treatment, investigation, birth history, past history. So I think she tried to do that way.
Okay. Okay. Thank you. Okay. So now let me quickly give my feedback where we can improve here. And on the positive front, I think her way of her opening statement, her introduction, everything was fine. Like she started well. and your way of talking, the speed and everything was perfect. And to give just one point of feedback I would add here. Whenever you start the history session, you can always start from what is given in the GP letter. Okay. So I happen to see this letter from your GP that your child is having this joint pain for 3 months. Can you tell me more about that? How it started and how it progressed? Okay. So that could be the letter opening statement. Just add up whatever information you get it from the GP. From that, you start your thing asking how it started and how it progressed. Okay. So that will tell you some more information about that. Otherwise, your intro was perfect. And whenever there is a joint pain and you think it is not related to trauma, then to decide between inflammatory and non-inflammatory joint pain, the main tool in history is the early morning stiffness. Okay, and whether any swelling is there. Okay, and here in this case, the swelling, the mother herself offered that the ankle got swollen and then it got better. Okay. Apart from that, one more question is you can ask is, did you find that any time of the day the pain was more? Like how the pain the child is getting up in the morning. Okay. And this is one clue where you'll get the information about the early morning sickness, indirect way of asking the early morning sickness to the mother. Okay. And when you ask the early morning itself, you can ask about nighttime pain, bony pain like that. That is one important differential for any general arthritis malignancy. So that will also rule out your malignancy. And obviously, this constitution symptoms, lumps and bumps, these all will add up as a point towards your ruling out your malignancy. Okay. And you mentioned Anita name thrice. Initially, you mentioned Annie, and then thrice you mentioned about Anita. So better before you go inside the session, always write. As I used to tell in my sessions, make sure that you write M or F mother capital and write the name clearly. Don't change mother name and child name, or don't give a name. So that will sound very bad. Okay. And always divide your paper into your three boxes. The upper box for your history of present illness and past history. And because this is a station where your diagnosis is not there, so you will divide this session as 9 plus 4 minutes format, where you will spend 9 minutes for your present and past history to ensure that you do a proper system screening and make sure you reach some points near the diagnosis. And the rest of the 4 minutes is for the other part of the history, okay, including your perinatal and growth and development, vaccination, family, and so on. Okay. So we always think that there is some hidden agenda in the top part of the history, which is your present and past. Okay, so try to do a system screening. You did almost most of the system screening. Maybe endocrine, you could ask something, because whenever you have an autoimmune disease, you can always put there is a possibility of an coexisting autoimmune disease already. So we have plenty of history stations having type 1 diabetes along with IBD, diabetes with celiac, and hypothyroidism with celiac, and hypothyroidism with diabetes, so on. Okay. So the format is, if the diagnosis is not clear, you will spend 9 plus 4 minutes. Okay, 9 minutes to essentially to get close to the diagnosis. If it's an old case, it's a chronic case. The situation itself, the information given itself is a known patient of diabetes, known patient of asthma. Then you make sure that you spend into, like, the time is like 7 plus 6, meaning the 6 minutes you allocate to the later part of the history, where you will ask more about the medications, the tolerance, and any side effects they notice, and what difficulty they have in using medication, and what are the complaints, and how the family is coping up, how the patient is coping up. Okay, so those part of the things becomes more relevant in that sort of a situation. So here you almost did the screening. Okay, that's maybe you can add one more few things. And when the mother herself commented that she had a concern whether she is falling down sleep and she is seeing it or not. So when the mother says a statement like this, then that is definitely a point to know whether the eye screening has been done or not, and whether she is on follow up with those things or not. So to put across, you can combine all these things because you did not have any symptoms of constitution or any bony pain. So malignancy essentially ruled out. So you have an two joint involvement and a disease of more than 6 weeks. So probably it is going into a JEA, a decreasing vision. Probably oligoarticular is a good differentiate. Okay, others, please mute yourself. There is a background noise, Dr. Uma. And coming to the past history, always ask about whether what are the drugs given. You did ask about that, and how long it is given, whether it is SOS basis or how many times it was prescribed, and if the mother notice any side effects to the medicines. Those things you should always ask. And vaccination history could be asked, particularly in autoimmune disease, because these patients will be on immunosuppression. So ensure that the vaccine is complete. And whenever there is a sort of a chronic illness or something like this, you will always ask about the functional impairment, okay, like how it is interfering with therapy. You did ask about that at the end. Maybe you can ask about it at the end of your present history, when the mother says that she's having joint pain, how it is impairing with her activity. There itself you can do that. Because your history time actually exceeded beyond the 30 minutes. We did give some extra minutes, that's fine. But it's easy to comment from this side of the screen, but again, during the exams, it has to be done. So that whenever you have a chronic illness, always ask for the functional limitation in the day-to-day activities. And again, coming back to the family history, again, this is your third part of your history, right? So you finished your present and past in your first column, that is fine. And the second part, you did ask about this perinatal and growth and development, all those things, then vaccination. Then the last is family and the social part. Okay, definitely there will be some hidden agenda in all these three parts. Okay, so if you put the right question, then the role player will tell out all those things. So here you asked about any problem. Then again, I told about a skin problem. So there it should be like you can ask more. What was the diagnosis? Can you tell me what was the problem? Do you have any names told? You can ask like that. Okay, or it is like how long? What is happening with that? Like that you can put some questions so that could also be a clue. Or maybe you get the second differential offer here is a JEA to psoriatic subtype because the father is having a skin lesion. Okay. And regarding the differential question, one of the Rafael has here, better stick on to 3 or 4 differentials. Do not give a lot of differentials. Okay. So better stick on to 3 or 4 differential and arrange them. As always, arrange them in the order of probability and always have 2 bad differentials in your diagnosis. Okay, whatever the case is, because demonstration is always about ensuring that you are a safe doctor there. Okay, so you should not miss out any bad diagnosis. Okay, maybe you can still have malignancy here down the lane, but as we have mentioned rightly, tell points against, points favor and points against. Okay, maybe the mother says sometimes the child feels weak or she thinks it's pale and there's a joint pain. You definitely want to do some blood count and smear as well in the and non-accidental injury, maybe you can keep it last line, okay? Unless you are very sure NA is to be kept in the last. So 2 common differentials we can have here is JA oligoarticular and JA psoriasis is a differential, and we can always tell points pair for and against. Okay? And you can bring the vision loss, particularly in JA oligoarticular, because I want to emphasize this point. This JA oligoarticular is not much a problem of a joint, it's more a problem of eye. The uveitis in JA oligoarticular is more of a subclinical uveitis. It is not painful, so there will be painless loss of vision. Unless the child is with the slit lamp examination, you will not be able to get the uveitis because most of the times there is proof for JA oligoarticular is age less than 4 or less, and female sex and who are ANA positive. So this is the specific cohort of children who will have an oligoarticular phenotype and they'll have this silent uveitis and they will go for vision loss unless it is being screened and actively managed. Okay. And summary, better try to give a quick summary. Okay, so as you are taking some notes or you make some at least some points like joint pain, okay, like JP and vision B and false F, like that, and family history of skin problem in the family. you try to have it in your paper at least some clues to summarize, because before you're going to give a summary, you can have just a quick glance at the paper and then tell just the positive findings, and if at all, you can tell some negative findings like no pointers towards malignancy apart from the pallor, doubtful pallor the mother had. Okay, and there is no evidence of non-accidental injury from the history. Always you can use medical terms in summary. Okay, summary has to be crisp and it should be short, telling only the positive points. So if you have just noted down all those positive points, you can just have a quick view before you're going to give the summary. Just have a quick glance and tell those things. So today I had the opportunity to take history from the mother of a 4-year male child, a 4-year female child, and she is having an inflammatory joint pain involving 2 joints in the last 3 months, as well as the mother has some concern in the vision, and there is a history of frequent falls. Okay. Other parental history is uneven too, and she has completed her exam, and there is a family history of skin rash in their father, and there is no pointers towards malignancy or malnutrition symptoms or non-accidental injury from my history today. Thereby, you close the history. Okay. And generally, after the summary, you will be asked to give a differential diagnosis. And the essence of history in MRCP examination is more about problem areas, identifying the problem areas, not about the differential diagnosis. So if you have identified the problem areas and then if you're going to give some 2 or 4 differential, that's fair enough, not more than that. Then the questions will be how will you investigate, how will you manage? And in management, I wanted to go beyond medical. So whatever problems you have identified, bring all those things in the management. Like she's having frequent fall, vision examination, and if she has a problem in the vision, then what are the other things you will do? Those things has to be in the management plan. Okay. So read about J from the guidelines and Mark. That's more than enough for you. Any doubts?
Sir,
And,
you told
if I go
something.
to-
Sir, you
Yeah.
told something about the taking a chronic complaint.
Yeah.
You told
I
something
was
related to that. I didn't hear clearly.
okay. I was telling about if you have a diagnosis in place. Say, for example, if the scenario says that the child is already known child of JAU in your GP letter, okay, then your focus should be more on the later part of the history, meaning the
Okay.
past, her drugs, her compliance, and how she is having any side effects with the drugs, and how they are coping up with the illness, and how the child is coping up with the illness at home, at school, okay, and then the family, the social front, those things will have the hidden agendas more.
Okay.
So there you divide as 7 plus 6, meaning within 7 minutes finish up your present and past. Then allocate those 6 minutes for essentially screening of those things. Okay. If the diagnosis is not clear, not known to you, so then your intention is to get close to the diagnosis and get all the problem areas with respect to the diagnosis. So you spend 9 minutes, full 9 minutes in your present and past. Okay, do a full system screening and don't miss anything there. Because if you miss the main system areas or main problem areas, then your diagnosis will go out of the question. Right? Even though we say that the essence of history taking is only identification of problem areas, not about the diagnosis. But still, if you are not having a close differential diagnosis, not alone the exact diagnosis, you will build exact diagnosis. Just if you are not able to give a proper differential diagnosis, then again your management plan will go away. Your discussion part will go away, right? Because there will not be any clue here from the examiner. Right?
Okay.
And one more information I want to give to for starting is like, even if you think that you have not come to the end of the history, which may happen for multiple reasons, don't be a bit upset. Okay, your information gathering is giving you only 2 marks here. Okay, so whatever the 30 minutes you are spending, that will give you 2 marks. The information is given 2 marks. Okay, just come to the other part, your clinical reasoning. So how you are going to take from the non-medical words of the mother to the reasoning out of the diagnosis or the chronicity or whatever it is. And from that management planning, that will give you 2 marks. Okay. And see this 4 marks for your rapport and communication style, verbal and listening skills. That will give you 4 marks. And I would say that you have done your apple communication style is good and your listening skills are good. There is no problem with that. So you did have show some sympathy in between, and then your communication style is good. You pause when the mother is talking. So those things are very fine. Clear?
Okay. Thank you.
Right. So shall we go to the clinicals?
Yeah, I wanted to do, sir.
Okay, Dr. Name?
Dr. Tanushree.
Tanushree here. Right? Yes, okay. So we will start, okay? There is nothing outside the clinical section. Okay, we just go to the section, right? Okay, shall we start? Hello?
Yeah, we can start.
Yes.
Yeah.
So, hello, doctor. So today we have a 4-year child, Winnie. She's accompanied by her mother. Okay? She is the janitor. And this is another station. Kindly examine her lower limb. She has some pain while walking.
Okay, do you want me to do her neurological examination or the MSK examination?
MSK. MSK, doctor.
Okay. Okay, I enter the room. I sanitize myself, and then I ask, how does the child's dimensions? How are the child's dimensions?
She is moderately brief.
Okay. What about any dysmorphic features?
No dysmorphism.
Okay, and she's not in any distress.
Not in distress.
Any walking aids?
No walking aids.
Okay. So I would just like to ask, does she have any problem walking up and down the stairs?
Yeah, she's having some pain, doctor.
Okay. And what about dressing and undressing?
No, like I do the dressing stuff and undressing. Sometimes she helps in undressing, but I don't think she has a pain.
Is there any pain or swelling in any of her joint?
No, I think her joints in her legs are swollen, doctor.
They are not
I'm not
swollen.
sure whether they are swollen.
They are swollen.
Yeah.
Okay. So then I will start with the inspection first. What do I see in her lower limb? Okay, so there's a distinct swelling of her left knee. So I can see that there's a limb length discrepancy also. And is there anything in the skin? Anything in the skin and any atrophy, hypertrophy of the muscles?
No skin lesions.
No
And muscle looks symmetrical on both sides.
symmetrical on. Okay, then I start with the look, feel, and move approach. I first check for the temperature. Is the temperature on both sides the same?
Yes.
And okay, and I try to feel for any. I first ask her like, is it okay for her to if I try to do the patellar tap? Is it okay for her?
Yeah, the examination is proceed.
And is it I try to do the patellar tap? Is it positive?
Yeah, the tap is positive.
Patellar tap is positive. Okay. So I first so and does the joint feel hot? The other one, no.
No, she is not having pain.
Okay, I asked her if she can move her joint on her own. First, her knee joint. Like I would ask her to do on the normal joint, and then ask her to do on the joint that is involved. First, I will try for active movements. How much is she able to move?
She is not able to follow you, but the mother is helping and to move her limb. She is able to move her right knee. Left knee, she is not able to do it full.
Okay, I asked her to move her knee joint, like, and then both the, and then the other side. To the other side, she's not able to move, right?
Yes.
Okay.
Flexion is difficult on our side.
Then I also try to move her one joint up, like her ankle joint. I want to do on both sides. Is the joint movement restricted on that on the affected knee? On the
What
affected
movement you want to do, doctor?
I want to move the ankle joint up upward towards the towards herself and then towards the bed. Like move the
ankle movement looks symmetrical on both the sides.
It looks symmetrical on both sides. Okay, and
Yes.
okay. What about the abduction of the ankle?
Looks symmetrical on both the sides.
Both the sides. Okay. Then after the ankle, I want to try to move her hip joint. I will ask her to do all the movements first. I will tell her. Can you, if she can lift lift her feet off the bed on the normal side first, and then I will ask her to do if she can do it on the other side, if it is possible. Is she able to
do the hip flexion, right?
No, I'm just trying to, hip flexion, yes.
Hip flexion.
Yeah.
Okay. Movement looks equal on both the sides.
Hip flexion she is able to do?
Yes.
Okay, on both the sides equally. Okay.
Yes.
After that, I also try to see if any of our upper limb joints are involved.
Okay, doctor. Time up. Summarize your positive findings.
Yeah, today I got to examine a 4-year-old child who has come with the main complaints of pain in her lower limb. And on examination, I found that her left knee is swollen. There is no raised temperature or warmth on that affected side, and there are no skin changes. But there is a severe restriction of movement of a knee joint on the left side, and but her ankle and hip movements are unaffected. I tried to, there was a severe restriction of movement on that side. And other than that, I can also see that there's
from your examination today, what did you for the diagnosis
just by seeing, just as it's a single joint involvement with no signs of inflammation, I would like to keep number 1, oligoarticular arthritis. Number 2, anthracite related arthritis. And number 3, it could be septic arthritis or osteomyelitis, but considering the fact that there are no signs of inflammation in that joint.
Okay, how would you like to investigate?
Yeah, initially, I would like to do the blood test, which would include the full blood count and the inflammatory markers. And along with that, I would also like to go for some antibodies like ANA and RF factor, and X-ray of the joint and ultrasound of the joint to look for.
Okay, doctor. How would you like to manage?
Initially, give the joint some rest, like ice and then some elevation splinting, so that it gets time to heal. Then analgesic would be required. For analgesia, I'll start ibuprofen in her and see how she responds to that. It will be given for at least 4 to 6 weeks. And if not relieved with that, I...
okay, any specific advice you want to give to this mother?
for the mother,
Considering your diagnosis of JAE.
yeah, she should not, the child should not participate in any active sports, and the optimal diet should be maintained, containing vitamin D and
Thank you, Doctor. Thank you. Yes. What is your impression, Doctor, before others? Where do you think you should improve here, or you think? Hello.
So in the management, she did not speak about the eye evaluation, which will be very important if she's considering oligoarticular JIA. So frequent ophthalmology follow-ups will be important in this child. That point she missed, I think.
Okay. Dr. Tanushree, like, what is your opinion? How is it?
I should have involved the multidisciplinary team, which I forgot to mention. And that would have encompassed the ophthalmologist role also. That was something I forgot. And
Okay, are there any
I
feedback?
think,
Yeah.
I think I did not check the gait also of the child.
Okay.
Even though the child was having difficulty, probably I could have asked her to see if it was an antalgic gait or.
Hello. Yeah,
Yeah.
I did not hear she introduced herself and took the consent to build up repo. She was not talking to the child, and what were she was not noting his expressions. Was it painful or not? She should have like said it, because we cannot say. Obviously, in exam she would be doing that maybe, but she should have verbalized that over here. And then if she picked up that leg length discrepancy is there, so she should have measured it with the help of that measuring tape. And then initially, if she could have, like, she picked herself that gate, if you could have assessed, so she would have lot more, the examination would have been more much more confident, and everything should have gone in the right place at the right time, right? Thank you.
Okay. So points whatever I have noted where we can improve here is, so after you wish the examiner and simultaneously you wash your hands, you also get to establish a rapport to the mother as well as the child. Okay. So get the permission of the mother. Is it okay, mom? Today I'm going to make the child move. Is it okay? And examine her limbs. Is it okay? So just introduce yourself and get the permission from the mother and the child positive. Okay? And for MSK session, go with the first three screening questions. Okay, as soon as you get permission from the mother, shoot down the three screening questions. Okay, so do you have any pain or stiffness in your joints or muscle or back? Any difficulty in pressing and pressing, and any difficulty with climbing stairs? Shoot down this question as soon as you get the permission from the mother there itself at that point. And so after these three questions, MSK, as I would always say, just remember this rule of three is, there are three things here and there. Okay, so you have these three screening questions. Then the next thing I want you to do is you ensure that you lift the trousers up, and here it's fine. But otherwise, in real exams, the examiner will ensure that the child is fully covered. Okay, so it will be purposely done so that you are supposed to talk to the mother, and is it again you talk to the mother? Is it okay if I put the roll the sleeves? So expose up to elbow and knees for both male and female. Okay. So with the permission of the mother, maybe you can, if you think the child is tense, because again the 4-year child, 5-year child, they may not be that much okay to suddenly lift it. You can always with the help of the mother, like, is it okay? Can you help me with that? Okay, then you can slowly build the rapport, and in between you can tell, I like your dress color. Just put some questions like your dress color is nice. Like that, so establish the rapport with the child also. And after you do this, lifting the shirts and the sleeves and trousers, remove the shoes. Okay, if the patient is wearing shoes or slippers, remove it. That is the next thing. And then you do a full 360 inspection of the front, back, including the back for scoliosis. Look for the size, front, okay? And then at that point itself, comment upon look for the plantar arches as well, whether there's a flat foot is there or not, all those things. And then do the gates there itself, okay? And then as gate, if not possible, you can, if you want to stick it to the end, then keep it very sure gate has to be done, okay? But as you are doing this full head to foot examination, you can always look at the back, ensure that there is no scoliosis, and by that time itself, ask the child to bend down and see, because if here we have a obvious swelling. In case if the child, mostly the child will be on some medicines, they may not have any obvious inflammation. You will not have anything to see on a visible front. Okay, and sometimes if it's hypermobility, you will never even go to that point unless the child is going to bend down and touch the floor very comfortably. You won't think of hypermobility, and because you will be doing here and there, then the hypermobility maneuver may be out of time. So do these three things at the beginning itself, like lifting the sleeves and trousers, and then removing the shoes and slippers, and then looking for a 360-degree full head-to-foot examination, looking for everything, including your back, making the child to bend, as well as look at the arch. And that point itself, you can ask the child to walk a bit, okay, for the gait. One.
This child
Okay.
had an obvious swelling. That's why I was thinking whether to, whether it would to make him walk or
Walk. Yes. Okay. If you are concerned that that is going to be painful, okay, then you do the clearance examination, the regional examination of the system, the look, feel, move approach. But at the end of your things, you have to definitely ask and as a child to ask at least the mother, is it okay if she could walk a few steps? Because even if you have an obvious swelling and you have done the clearance, you have to do fegals of the lower limb. Okay, which includes gait also, like walking normally and walking on 4 foot and walking on hind foot. Without that, figures is not complete for lower limb. Okay, because only by doing those stress maneuvers, you'll be able to pick up anywhere else if there is a joint pain. Okay, so if you like it, you do it as per the comfort of the child and as per the flow. Okay, so but ensure that you are doing this. And when you're looking for this 4Ds, also look for any glasses, anything like that. Okay, in general, because these patients may be on steroids, they may have cataract, they may have cushingoid cases. So again, here your examination of MSK system in general, apart from the 4Ds, you will also comment upon skin, which means skin, nails, and hair. Skin means skin, nails, and hair. Just give a quick comment about this skin, nails, and hair. Okay, at least say that you want to do that. Okay, at least just pretend like you are just seeing the nails and looking at the hairlines, looking at the skin when you're doing this studio inspection. Then you will again comment upon the muscle bulk you did that. Okay, so comment on either side symmetrical. And then here itself, you can comment about the swelling. Swelling, whether it's a bony swelling or a joint swelling. So if you are seeing swelling around the knee joint, then you will give this the parapatellar fullness is there. Okay, the parapatellar fossa is full on the left side compared to the right side, and there is an obviously swollen left knee joint. Okay. So then you will do the feel approach. Okay, so then you will comment upon not warm, not tender, whether joint tenderness is there or not. And then you can go for the specialty tests like fluctuation or the patellar tap. Then you comment upon fluid and tell about the consistency. If there's a swelling, you tell whether it's a fluid or whether it's a bony swelling or it's a synovial swelling. Then movement approach, as you told, you have to do the normal limb first, then the other limb. Most of the time, when it's a small child, you will get the help of the mother. Okay? So try to establish the rapport with the mother, and you can ask the mother, is it okay? Or just ask in between also, is it okay if I could move the joint? Okay, let me know if she's having pain. Okay, like that you can always comment that whether she's having pain, stop me if I'm having any pain. Okay, so always look at the child's face when you're moving the limbs. And comment upon one joint above and below which you did correctly. Okay, so even if you have a swelling in the knee, you have to comment upon the hip and the ankle. Now, how will you test the hip joint movement? So one you want to test is flexion and extension. What about the other movements, particularly the internal rotation and external rotation? How will you test that?
So internal rotation I can do on the normal joint, but it is going to be very painful for the other.
Painful.
Could be very
Okay.
painful. Yeah, that is why.
Yes.
That
Okay. Okay. So you will do it on the normal joint first. So how will you do that? Just want to. So if it is going to be okay. So the thing is, internal rotation, external rotation tested by flexing the knee joint. Get the point? Okay. So you will do flexion either in the supine or the prone position. You will flex the knee joint, and then you will keep your hand at the ankle level and move it sideways. Okay. So going out, move the ankle out will test the internal rotation. Going in will test external rotation. Are you able to comprehend what I'm telling? Just a minute. Say, for example, if this is the child and you are examining this uh, knee joint, then it should be like you can ask the child to turn prone and then flex at the knee and then do this movement. Okay. So
just a question. Can I ask
yeah.
you a question? Like in order to show the movement, since he's not having any pain in the normal leg, can I show the movement in the normal leg and ask him to do the same on the affected? How much he can?
Yes. See, you will not do all this movement. Just I want to comment that because only this internal rotation, external rotation requires the knee joint to be flexed. That is the point I want to highlight for today. Because many times the examiners may ask this question and we will be comfortable in doing such an exception, but we may miss point of location. Okay. So you will always have to do the normal joint first. Okay. And by the time you go to the swollen joint, the examiner will say no normal to do. So it's with that step. Okay. And whenever there is pain, the examiner will stop it. Okay. So just for your knowledge sake, I want to tell that if you're doing this rotation, ask a child to lie prone, okay, and then flex at the joint and then do this movement sideways. This will tell about the internal and external rotation. And regarding whenever
So
the
why prone, sir? It can be done in supine also.
You can do it in supine.
Yeah.
But again, if you are doing in supine, it will not be purely internal external rotation. There will be there some degree of abduction or action will be there. Like say, for example, if the child is lying like this, okay, again you have to flex the joint, right? You get the point.
In
For
to
the
say
true movement,
I'm talking about the hip movement that can be done in the supine position also by flexing the knee.
yeah, but again, there will be some degree of abduction and adduction if you are doing it in supine.
Okay.
It will
Yes.
not be pure internal rotation.
Yes.
Get the point.
If you make him prone and then do it, so in prone, how will we do it, sir?
Which one?
Prone position, how will it be done?
So imagine if this is the child, okay? You make the child to lie prone, okay? And you do it will flex at the knee joint level, okay? And move the keep of the finger at the ankle level, move it like this and this. Get the point? Sideways. So going out will be internal rotation, going in towards the other limb will be external rotation. Okay.
Okay.
Right. And whenever, as I always mention, whenever the knock is given, give this in order to complete my examination. It is very sure that many times we will not be able to do a full examination in the 6 minutes. That's understood. But the point is whether are we intending to do all these things if we get a time. Okay, so tell these things in order to complete my examination. I want to do, particularly if it's MSK, you want to do functional testing. Means if it is for lower limb, you will comment upon about how they are walking the gait. Okay, so that if you're not able to do, you will tell in order to complete my examination, I want to look at a gait. Okay, and if it is, say, for example, if it is upper limb, you will comment upon this drawing skills or holding it up and all those things. Okay, and limb length. So limb length, you mentioned that to my examination, to my observation today, there is an apparently the limb looks, there is an asymmetry in the limb length. However, I would like to confirm by taking measurements. Okay, so how will you take the measurements from anterior iliac spine to the middle malleolus if there is no deformity? Okay, if there is a deformity, say for example there is a flexion deformity of the knee, then you will do it from anterior iliac spine to the tibial tuberosity, and then from tibial tuberosity again to the middle malleolus. You break it into two parts because there is a deformity at the knee level. Clear? Similarly, for the upper limb, it is from the acromion process to the radial styloid. Okay. If there is a deformity at the elbow of elbow, then you will break it at the point of the olecranon. Okay. Now these things are never done. Means there is no time for all these things. But in case if the examiner wants to ask you a question, if there is a deformity, how would I like to do a limb measurement? Then you should know how to make it. At least say in order to complete my examination, I want to do a proper limb measurement. That is one. And always formal eye examination is a must. Okay, that should be told in order to complete my examination. I want to do these things like a functional assessment, including gait, and then limb measurement. Okay, and then formal eye examination and examination of skin, hair, and mucosa in detail. Okay, and then obviously tell about your vitals and plotting the height and weight and centile chart. These things are like, see, there are few things which you can control even before the start of your phase or whatever it is.
Sir,
these things can be written.
whatever you are saying, all this will take up my time of that 3 minutes for Viva. So that time gets shortened.
You just tell all these things continuously. The examiner won't break you. Like whenever you hear the knock, just tell all these things within a few seconds, 10-15 seconds. That's all. You're not going to, like elaborate like what I told now. You would not to complete my examination. I want to do a functional assessment, including gait. I want to measure the limb length. I want to plot in centile chart, as well as measure the vitals, as well as do a formal eye examination, and including examination of the skin, mucosa, and hair in detail. So it took 15 seconds. So it will not take 3 minutes. Because unless you are going to see, if you are going to miss something, you can always include it in order to complete my examination. Like if you miss gait, please include it here. Okay.
Okay, sir.
And advice again for all this, if you think it is going to be a chronic illness, you will tell about counsel regarding the chronicity and the follow-up at regular intervals. If it's going to be a patient who is on autoimmune disease, again, counsel about the signs of infections and how to avoid infections, avoiding overcrowding, and vaccination advice, and steroid bracelets, all these things. And you will not tell, you will make the child to avoid physical activity or play activities. That is strictly not to be told like that. You will tell a counsel about doing gentle exercise, like swimming, like cycling. These are exercises which are proven to have beneficial effect once the acute inflammation is taken over. So you will not restrict the activity of the child. Okay. So you will tell like I will go with the RICE approach of rest stimulation and compression, all those things when the joint is in pain. But after that, I would put the child on gentle regular exercise like cycling, swimming, and all those movement. Okay.
I have a
Not
question.
strength training, but movement exercise. Yeah.
I have a question. So, what should be the appropriate differential over here of a monoarticular arthritis? It could be acute, it could be chronic. In chronic, we can include oligoarticular, and in acute, we should keep this thing in infection.
There are only 4 differentials for acute joint for all purposes, at least for the MF exam purposes. One is the JU. Okay, that is the commonest, and that is likely to be the case to be in exams. Okay, and other thing is the bad differential is the malignancy. So there you may have leukemic arthritis as well as bony pain, generally not written exams. Okay, then the third is post-traumatic hemarthrosis, or if it's a male child, again hemophilic hemarthrosis. Again, it is going to be very painful joint in the acute phase, at least, and again not written exams. Okay, the last one is septic arthritis. Again, it is going to be a red hot joint. It will be painful in the initial phase, but on antibiotics, they may have some amount of improvement. So they may not look a red hot joint when on antibiotics.
So please
Yes,
can
can
you
be
repeat,
included.
please can you repeat the DDs, sir? 4 DDs.
First is the commonest is JA oligoticular. That is the case which is likely to be in exams. Okay. And second is a bad differential, which is leukemia. Okay. They will have diffuse pain, body pain. Okay. They may have joint swelling as well. Third is the hemothrosis. That could be post-traumatic or it could be hemophilia, whatever it is. Then again, it is going to be very painful, very tense and painful joint in the acute phase. But on the later front, it may have less amount of inflammation. Usually, again, not better. The last one is septic arthritis. Single joint septic arthritis is a good differential, but again, not written exams because obviously child will be sick, febrile, toxic, will be a tender joint. But again, when the child is on antibiotics, improving, maybe at the end of 4 or 5 weeks, the child may not have that much of signs of inflammation. Okay.
What
But
about reactive
for your
arthritis?
differential for the single joint, we can offer all these things.
Okay, thank
Yeah.
you. What about reactive arthritis?
Which one? Reactive. Yes.
That is
So
also more particular to going with this child's present.
Okay. Yes. So reactive arthritis, there is no term for reactive arthritis generally in pediatric age group. They call it as an ERA group. Encephalitis arthritis, JA ERA subtype. Okay. Again, it is going to be lower limb predominant joint, usually asymmetric. Again, oligoticular type. Like it will be like 1 to 3 joints, lower limb, predominantly large joints. Okay. So if you bring it under JA, then it's fine. Maybe you can give it a separate subtype like JA oligo or JA psoriasis or JA ERA subtype. ERA will bring everything, including reactive and psoriasis.
Okay, thank you.
So I have a question regarding a short stretcher. Yeah. So how can we differentiate disproportionate short stature, like on a visual examination? Like this child is having a disproportionate and proportionate stature without measurements.
Yes. You will tell, see, obviously if it is achondroplasia, then you will comment. Is it not? That is the most common case if it is short stature. Or otherwise, you can always tell that to my observation today, this child, so and so, 4 years, looks disproportionately short. However, I would like to confirm my observation by taking measurements.
Okay.
This will be a safe statement. Okay. And if it is a short or a tall stature, if it's a short stature, you have to do the sitting height. And then you will take the total height and then you will do this minus. Okay. But definitely there won't be time in those 6 minutes. But as soon as you hear the knob, attempt to take the inch tape in hand. And tell that in order to complete my examination, I want to do the sitting height and do the comparison between the upper segment and lower segment.
Okay.
That will give an impression that you are aware of the things to be done, but because of time constraints, you are not doing it. So you will tell, to my observation today, this child looks proportionately short or disproportionately short. However, I would like to take my measurements at the end of my examination.
But sometimes we didn't get an idea just from the observation whether it is a disproportionate or proportionate. Suppose if we are saying wrong to the examiner, and then do they cut the marks?
I don't think if you think that is not that much pretty obvious, then it is well recognized and understood that it is not possible to do all the measurements in those 6 minutes. Okay. But if you are doing this short stature maneuver, and if you don't do this bringing the hands together and all those things, if you are not doing this overshooting, undershooting, you're not picking up at that front also, then they may reduce the marks.
Okay. All right.
Okay. If you're not able to point out the asymmetry at that front when you're going to do this hands together or doing this thumbs to the shoulder.
Doctor, I have
Okay,
a
sir.
question. If it is a obvious short statement and the command is for journal physical examination, and you could clearly see that the child is short, so isn't it a must or mandatory that you should go for the short height maneuver or not?
See, if the command is to do a general examination and proceed in accordance with your findings, if you think that the child is short, you will again say that, to my observation today, the child looks short, so you want to do the short stretcher maneuver. As well as do a head-to-foot comment on the general examination when you're commenting about the 4Ds itself. Give a quick impression of the head-to-foot examination. In general, see, this is what I used to tell in our regular classes, that usually the child in examination is around 5+ years, because generally this 3 years, 4 years child, they're not that much cooperative. So it is around 5 to 10 years child, usually in examination. Okay. And if you take 5 to 10 years child, they will be above your waist level in general. Because why I'm saying this may look very trivial. Sometimes when the examiner says do a general examination, he may even forget that the child is actually short. Okay. So to give a clue about that, if a child who is 5 to 10 years old is not reaching up to your hip level, he is definitely short. And that is the most common age group likely to be in the exams. Okay. And the most common short stature case will be likely to be achondroplasia, or it could be an MPS child with other deformities as well, giving a short stature. These are the two common cases available. And then growth hormone, all those things is possible. And then patient who is having a chronic illness on steroids, this iatrogenic Cushingoid with short stature, that will be the next case. So these are the few common cases of short stature. You will MPS, obviously you will know all this dysmorphic findings, and Cushingoid will pick it up. If it is going to be achondroplasia, again you will get the typical phases of achondroplasia and you will pick it up. The thing is, sometimes we may not recognize that the child is short, so we may not do the short approach itself. So for that purpose, if a child is 5 to 10 years and is not reaching your waist, always think the child is short.
And I can offer these measurements at the end of my examination or at the start or in between?
Definitely. I strongly suggest not to do these DP measurements, not to do these in-state measurements at the start of examination, because that requires some cooperation from the child, and that requires making the child to move here and there. And you have only 5 minutes in the exams. After you do the hand washing, hand over the papers, introduce yourself, you have only 5 minutes. And if you start taking the in-state, you want to do the sitting height, total height, then definitely your time is, you may miss the major things.
Okay, thank you.
Sir, I have one doubt.
Pretend like taking the in-step at the end of examination when the knock is about to come or the knock has come. And under opening statement, when you are seeing the child head to foot, you can tell, to my observation today, the child looks disproportionately short. However, I would like to take the measurements at the end of examination, including the sitting height, and compare the upper segment lower segment ratio. So if you give this statement, if say for example you are the examiner, you understand that the candidate knows what to do, but he wants to do it at the end, but he is aware of what to do.
Okay, thank you.
Yes.
Dr. Shabri, I have one doubt.
Yeah.
Initially, you said that we could ask some questions while examining. Is that allowed? Like history type questions are allowed while we are examining?
Only in MSK.
Only in MSK, right? Okay.
3 screening questions are allowed, are mandatory in MSK.
Sir, can you please repeat those 3 questions?
So, did your child have pain or stiffness in the joints, muscle, or back? Okay. Does he or she have any difficulty while dressing and undressing? Does he or she have any problem while climbing up and down the stairs?
Thank you.
So, what are we now? Okay, we have done the clinicals. The examination today, I mentioned, please wait. Okay.
So
Please
I have
repeat
one
these.
doubt, sir.
Yeah. Yeah.
So,
These are clear, Dr. Bintul.
sir,
Yeah.
Yeah. So in a short stature case, is it possible that the examiner can give us like growth charts at the beginning and say to plot like in that short time? Like, is it possible that they may give us like a pink or a blue chart and plot?
Generally not done.
Generally not done.
Shaurya,
Okay.
Not done. Because
Shaurya,
exam also knows that the time is an issue.
किस हो रही
Generally
है?
not done.
Okay.
देखा भी नहीं तुमने उसको, वो सो रही है.
So, like, who wants to do the next one? Next we have is communication. Who wants to do that? Somebody told in the group.
Yes, sir, I will do. So my name is Dr.
Your name,
Priya.
doctor? Hello. Yeah, your name, doctor?
Priya.
Okay. Okay. Let's your time starts at 3 minutes. Okay. Please repeat it. I think we have done that hemophilia. Yes. Hemophilia is secondary to hemophilia or post-traumatic is a differential for a monoarticular joint. And one point I want to highlight here is whether it is arthritis or whether it is any other case, don't expect any typical findings. Even if it is CP case, don't expect any typical hypertonia, all those things, because the child will be on treatment. Only the child who is on treatment, who is comfortable, will be taken up for examination. So keep those things in your mind. Just don't get deviated from your human vision just because the child is not having typical hypertonia, what we used to see in a typical CP case or a typical MSA case, where we have a typical synovitis or arthritis. Sometimes child on drugs may not have the classical signs of inflammation.
मत लेटो, उधर जाओ. वो बिल्कुल नीचे हो रही है.
Others, please mute yourself. Yeah. Yes, sir. So, like, doctor, my child is had this bad cough and fever, and then he was not taking the pills, and then we got admitted here, and he was given some medicines, and now I think he's better. And the doctor the rounds told me that soon I'll be discharged. Hello. Hello.
She's muted, I think.
Hello.
Yeah.
Sorry. So, yes, Liza, you were right. Like when she presented, she had fever and cough for the past 3 days. But when we did the investigations, it came it says that she had some fractures also. So we will not be discharging her.
Oh, okay, doctor. Like, okay, you mean to say that my child is having fractures? May I know where is where is the fractures, doctor?
Yes, the fractures are in the ribs. So are you aware that like how okay, did she get the fractures?
No, doctor, I'm not aware, but I was not told anything about that, doctor. I was told that my child is having some sort of a lung infection, and now he is getting better. This is what I was told, and it's been shocking to me. Like you are telling that my child is having fracture. Yeah, I'm not aware of this, doctor.
Okay, Liza. So I appreciate. So she is having these fractures. So we will be will not be discharging her. I'm sorry about that. And we will be doing running some more tests to know what condition is she having. Like, are you
Oh,
getting me?
you, yes, doctor, but I'm quite surprised that I was told initially that my child is fit about to get discharged, and then now you're telling you're going to do further tests. Like what further tests, doctor? May I know that because, like, doctor, does he before that does he require any treatment for the fracture, doctor? I'm afraid that is it going to be painful to my child or is it going to harm him?
Okay, I appreciate Lisa, but because she is just 8 months of age and she's having some these fractures. So we are also suspecting non-accidental injury in this case. Are you aware about what is non-accidental injury?
No, doctor, like it sounds complex. Like, what is that, doctor? Like, is it going to be something a point to worry?
Yes, we will be, as I said, that we will not be discharging her. We will be keeping her in our in the hospital, and we will be doing some tests so that uh, any other things that we can rule out. Some like we will be doing some blood investigations. We will be doing some more X-rays, and we will be doing some brain scan also. So we can rule out if he's not suffering from any like a chronic or something bad disease. Are you getting me?
No, doctor, actually, it sounds you told something non-accidental and then you told you want to do scan of the brain. Does my child have any problem in the brain, doctor?
Uh, so, uh, yes, very good question, Lisa. Yeah, because she is 8 months of age and having a rib fractures is not common, and so that's why we will be doing the screening in her, and we will be ruling out if she's having any other problem, any other blood issues or any fracture anywhere else. So that's why we will be doing this.
But why you want to do scan of the brain, doctor? I'm not able to understand that. Like you have already done the X-rays and you have shown me that like is there any treatment to be done, doctor, before that? Because he told me that he's having fracture. Like, are you going to do some anything for him for that? Are you going to give medicine or what is the next thing you're going to do for that?
Yes, so we will be doing some more investigations, and as she was born preterm also, so there can be chances that the bones are weak, uh, uh, and we have to rule out that. But we are thinking in terms of non-accidental injury also, so that's why we will doing the further investigations.
Uh, Doctor, I'm not able to comprehend that. But doctor, are you saying that this is like somebody has injured my child? That is what you're telling that non-accidental. Is it so?
Yes, Liza, I'm not saying that you have injured, but yes, someone might have injuring Alice. So we need to rule out that.
Oh my God. But are you suspecting me, doctor? Like because I'm taking care of my child, and are you telling indirectly about me?
No, Liza.
Which means,
So how many? Yeah, very good question, Liza. So I wanted to ask, how many members are there in your family? Who is taking care of Alice?
oh, like myself and my husband is there, and we are taking care. And sometimes, most of the times, I'm taking care, and sometimes my husband takes care. But like, doctor, like how strong you are, doctor? You are affecting my family in this, and I will take it ahead, doctor. Like I want to talk to the consultant, doctor.
uh, yeah, Liza, as a concerned mother, I can appreciate like you are concerned about Alice. So are we. So that's why we want to. So to be Alice to be in a safer hands, we will be doing this test, and we are not sure as of now. But yeah, if you want to go ahead with the meeting with the consultant, I can arrange that meeting also. But right now, our plan is to admit her and do the further investigations. And I would also like to involve the social service team.
Oh my God. So you're going to mention the social service stuff. Okay. Okay, doctor. I will go to the judiciary. I want to complain and can I, okay, fine, that's fine. I will do that. But can I take my child to home after you do all the tests? Is it fine?
So yes, if we do all the tests and everything comes out to be normal, then we can plan and we can discuss that in another meeting.
No, but the thing is, my other child is at home and I need to go to home because yeah, I'm not okay with you are telling something safe and unsafe, and I know the law here, and I cannot just agree with what you are saying. I want to talk to the consultant.
Okay, Lisa, you can for some time you can go and then you can come back. And if you want that, we can also involve our team. So they can also go and they can take care of your other child.
No, I don't want that.
Okay, Lisa, so you can go and come back after some time, but he will not be discharged. She will not be discharged. Sorry.
Okay, Rota, I will talk to the consultant. Thank you for your information.
Okay. Okay. Thanks for talking to me.
Okay, yes. Where we can improve, how you think it went? So what is your feedback, doctor?
Uh, Sir, I think I messed up a bit in he or she. Sometimes I was using he and sometimes I was using she. And
Okay, others.
Yeah, I have few comments over here. Can I give?
Yeah.
Yeah, so yes, one she pointed out rightly, he and she, and the other was she did not ask for the attender of the meeting. And next is it was a case of NAI versus rickets of prematurity, as they mentioned very clearly that this thing is there, like
Yes.
premature baby was there. So you should have told about PTH and that vitamin D levels they are given in the safeguarding guidelines. So that you have to mention. And the other thing is imaging studies. He was not getting you because you were not clear like what kind of imaging. So bony problem found there, and then you will go for the imaging studies. Skeletal survey plus brain imaging. So he was asking what there in the brain. So brain maybe bleed is there. So somebody is harming. So yeah. So everything else is quite explanatory. Yeah. But this thing he was not getting it. Something which parent cannot get it. So you might draw something maybe to. But since you were looking confused yourself, that's why maybe CT brain he was again and again going around like what there in brain, what there in brain. Yeah,
yeah.
like that.
But again, drawing may not be an act when it depends upon if it's going to be information giving, then drawing is essential. I would say one drawing is equal to 1,000 lines of communication, whatever it is. But if it is going to be something like an confrontational one, then drawing may not be apt at that point. So you decide how it goes. Okay. The scenario can go like an information giving scenario, or it could go like sort of an confrontation with the role player, like saying that you are going to do safeguarding and take away the child, all those things. Then it may not be a apt thing to draw at that point.
Sir, I want to ask you in this type of non-accidental injury scenarios, from the initial minutes, we have to disclose to the mother that we are suspecting the NAI in your babies, and what is the NAI, and that might be a possibilities that someone is harming your baby, and that's why we do not discharge, and we need some investigation, for that investigation, just to make sure that everything is all right with her. Then she might understand and agree with us for the admission.
Okay. See, please read about the scenario, whatever is given once, twice. Okay. That is one thing. Okay. Your task is to talk to Mrs. Lisa about the reports, further management plan, and address the concerns. Okay. So about the reports, you have to tell that the agenda is tell about the fracture. Okay. Further management plan is not decided by you in singular. It is the team which is going to decide the management, and the consultant is on the way to re-examine. Okay, and you have already informed the consultant, and you are asked to cancel discharge. So your point here is to agenda is to tell about the fracture and tell about the cancellation of the discharge, and then the concerns whatever that comes on the way. Okay, because as the role player was asking, I want to meet the consultant. There is already enough hint given that the consultant has already been informed about this. He's brief, and he has only told to cancel the discharge, and he is on the way again. Okay, that may be one sort of reassuring here. Nowhere in the scenario it is given any. They have given it as multiple fractures. Okay, that is fine. But there is also clues towards like a strong neonatal force of RBS. Maybe the child has been given CPR there. Nobody knows. Okay, there is 40 days of treatment, which means the child may have a chronic lung, which is there itself, whatever it is, on referring steroids, something like that. Again, that may cause sort of an weak bones, or diuretics causing weak bones, or osteopenia to maturity itself causing weak bones, vitamin D, calcium deficiency, all those things. There are so many things here. The idea is not to jump to any conclusion, but tell the mother calmly that we have so many things as well. We need to rule out that. Don't use the term NAA upfront. You can tell that we need to rule out that the child is not being harmed by anybody. We want to ensure that. That is a more reassuring turn to the mother, rather than telling non-accidental injury or somebody has like there's a chance that he is bringing to a non-accidental injury. That they can tell, we want to ensure that the child has not been injured by somebody else. At the end of after telling all these things, we need to think, we are thinking so many things, as well as we need to ensure that the child is not subjected to any sort of trauma. Okay. And here at this point, you can always ask, like, do you have any thoughts about this? Do you think what could have caused this? And then you can put an open question here. Okay. Generally, in communication, you are not expected to gather any further information. That is the baseline rule. But there are few scenarios where you can put an open question. One is a scenario like this, where you can always ask the mother, okay, do you think of any sort of, do you have something in your mind that might have resulted in this sort of risk factor to your child? You can ask a point blank question like that. Then mother may tell, I am being the child to some nanny, or some my spouse is taking care, something like that, or some play school, or whatever, it is depending upon the case. And there are very few scenarios. I would say one is a bad colleague. Okay, when you are being asked to talk to a bad colleague who's coming late, who's going early, who's not filling up the discharge summaries, or who's not having a chaperone, or whatever it is, you can always ask the question, okay, is there anything from your side? Can you tell me your side of the story? What is bothering you? Is there anything bothering you? Because he's a colleague, you can always ask an open question there, asking if something else is there, because there can be hidden agenda there again. Like here, we have a osteopenia and so many things there. The colleague may tell that he is having a family trouble, or he is not well, or his spouse is not well, child is not well, etc., whatever it is. There is hidden agenda. Again, there can be a scenario where the role player is persisting for something. Like, I want a CT brain, I want this investigation, I want this test, I want that one. I will not accept for this. There again, you can put a subtle open question. Is there is anything which is bothering you at present? So that's the reason you are not you are persisting for this, or you are asking for this, or you are not saying agreeing for this. Okay, these are very few scenarios where you can put an open question. Otherwise, generally, you don't ask any further question from the role player.
Okay.
Okay,
So,
now
Doctor,
regarding, yeah, I'll just finish the feedback here. Um, so regarding one more feedback I want to do is you use the term I appreciate. Okay. So sometimes appreciate may not be the right term. When the mother says, I'm worried, you are telling there is a scan to be done, there is a fracture. You are like, you may use more words which will understand my sympathy rather than showing sympathy. Like you can tell, I understand it's going to be, I'm giving a lot of information like that, you can tell. Okay. So I understand that I'm giving you some new information. You are expecting discharge. I'm sorry for that. Like that. Okay. So change your words rather than telling I appreciate. Yes. Somebody was asking some question. Yeah.
suppose in these scenarios, if we are very sure about the non-accidental injury, like they are given like torn frenulum or there is the bruises around the eyes and something like that. In that type of scenario, can we open to the mother directly that we
If
are
the stem
suspecting?
says, if the stem says the diagnosis of NA was made,
Mhm.
then the agenda is committed openly.
Okay.
If the
Okay.
stem
Okay. All
doesn't
right.
say anywhere NA, you don't make it anything. You don't diagnose anything by your own.
Mm-hmm.
Stick on to the whatever is given. Even in that scenario, if there is a bruises here and there, you will tell that you want to do some blood tests, okay, some gene tests, okay. Then
Mm-hmm.
you will also tell that you want to ensure that the child is not injured by somebody.
Okay.
That is at the last. Always not NA at the top. You will not tell NA at the top and then tell about gene test, blood test later. Because by the time you tell NA, there is going to be a backlash.
So, what if we do not say this is an A? So, we will tell her that this is the fracture we have found, a rib fracture. So, what we will be doing next? What we are expecting? Like, what would we are doing?
Yeah, you can tell that, but again, you can include NA at the last of a differential because there was some point like varying stages of healing. You understand the stem here? There are presence of 4 rib fractures at varying stages of healing. That is a point for NA. Again, there are a lot of things here. Unless there is a diagnosis given in your stem, you don't assume any diagnosis.
Okay.
That is the final word. Okay.
Yeah,
So,
that I got it. That I
yeah.
got. But what if I am reading this scenario and I am telling the mom that I am going to withhold your discharge? So she will definitely ask me, so what are you going to do? So obviously, I am not having any diagnosis at the moment. So I will explain that my consultant is on way and we are like based on those injuries, we will be conducting few blood tests as he had some neonatal problems and some things might be there. So we would be like vague. Huh? And
Yeah.
then,
You tell all those tests, and at the end of it, also include that we want to ensure that the child is not being injured or getting some sort of injury because he is having these multiple fractures.
okay, okay, thank you.
Because the mother, if you see the communication, the mother asks, "Can I take the child to home?" So at that point, you will tell that if other reports comes normal, then you want to at least ensure that the child is not being injured. Then you can put a question there like, do you think how this could have happened? Do you have any idea or do you have any thoughts about how this might have happened to your child?
So, are you saying that at no point in this communication we will say that we suspect that it could have been caused by it may not be a accident, something like that? So, are you saying that at no point should we tell the mother that we are suspecting non-accidental injury in this child?
No, I'm not telling that. I'm telling that you will tell about the possible differential. You will not come to any conclusions. You will tell you are canceling the discharge, you want to do further test, consultant is on the way, you are thinking multiple things so that you want the child to be here at the hospital. That is your conclusion at this point of time. And in that differential, you will include an A, but at the last, definitely. Okay, clear?
Okay, sir. So, sir, I started actually. I started with are you aware like how she get the fractures? So, is it
You
right to
asked that,
ask
yes.
upfront?
No, the point is you will tell you what is the agenda, what is that you know about. There is so much of fractures right now, and because he is born early and he had like you look at the old records, and then it showed that he had a tough time at the birth in the ICU. Like there are chances that he may have a weak bones. There are chances that some of the medicines used during those periods may have made his bone weak. So you need to work upon those lines. You need to do a blood test to confirm or refute that. Okay. As well as there are some gene issues which may cause these other problems. So you want to do those things also. Okay. As well as you will tell, I want to ensure that child is not subjected to sort of injury by somebody. Okay. At that point, you can put a question. Okay. What do you think, Mrs. Lisa? Like, do you have something in your mind which might have resulted in this sort of action?
And if the mother that time, if the mother says like, yeah, I know my partner is maybe affecting or something like that, if the mother says, then I go towards NAI.
Yeah. Then you will tell that, oh, thank you for giving my history. Our consultant is on the way, and we will inform the social services. We are here to help you with that.
Okay.
We will do some tests to ensure that the child is not being injured at other areas. Okay, so we may need to do a scan. We need to do eye examination. Okay, we will ensure that you are under safe. You are in a safe place. That you will tell. You will thank the mother if mother gives forward to that waste. Then you will tell what are the next things you will do. But you will always tell the consultant is on the way, and you will ensure that you and your child is safe.
Okay, sir. And sir, one more question. When I'm asked the scan, is it to just to rule out bleed, or should I add more or something more about the scan?
Generally, CT brain is done to grow in that kind of bleeds if it is an infant.
Yes, sir. Sorry, I missed.
Generally,
What's it?
CT brain is done to rule out intracranial bleeds if it is going to be an infant. The safeguarding protocol is 60.
Thank you, sir.
Any other doubts or any other controversial points? Okay, I think then we'll go to the video. Who wants to the video? Just about like, see, it feels like if you start telling and the mother argues very heavily, I know the judiciary, I will take my child out. What will you say?
Sir, then I will say that for the benefit of for a child, we want to keep her in the hospital.
Yes. But the mother says, I know the judiciary. When you say that safeguarding, the child needs to take care. Mother says, no, I know the law here. I know the judiciary. What will you tell? You will tell that it is the law of the land. It's the same law of the land which is asking you to admit your child to ensure that the child is safe. Okay. You will use those lines. You will tell that this is the same law of the land which is insisting us to admit your child. And then, if the mother says another child is there at home, then you will not tell, you will send a team from your hospital. You will tell, we shall inform social services to help you with it.
Sir, what we will say?
We shall inform social services who will help you with that.
Okay.
Okay. we can arrange to take care of that. You will not send any team from the hospital for to the force. That doesn't work. And if the mother says, "Can I stay along with him?"
Yes, she can.
Yes, yes. You can stay. All right, you can stay with your child, but you will be under our observation. There is always a if and but. Okay.
And sir, if the mother says that I will go and then I will come back for some time,
No,
for some.
no, no, no. You will not say no, as I'm saying no. You will tell the false way. I'm afraid, it is not possible to discharge your child right now, considering his best interest.
No, sir. If the mother says that the child would be there, I will go and then I will come back.
No, that you can discuss. That's fine. That is not interfering with your activity again. But then again, yeah, that we can talk over, Mrs. Lisa. That's all you. That should not be an issue.
Okay. Thank you, sir. Thank you, sir.
Okay, who wants to the video? Right. From the group. Can we stop here or you want to do the video? Hello. Audible? Hello.
Can't see the video, sir.
Like who wants to do the video? Somebody is ready to take it, or we can stop here. Okay, Dr. Pankaj. Okay.
Uh, is there any rash in the back?
So you can go again back into zero. Yes, thank you.
Is there anything in the eye?
Do you want to go to any part of the video? Okay.
Yes, yes, sir. Yes, sir.
Which one?
Initial part, I could not see. Okay, sir. I think I can try.
Yes. Yeah.
Alright.
Okay.
So I can see a toddler who is in a stretcher with mother comfortably in mother's lap. You can see that there is no obvious dysmorphism and distress, and there is no devices attached, and looks well grown for age. But I would like to plot. I can see in the video that the child is looking a bit anxious, and lips are very red. There are some disformation and swelling of the fingers, and also a disformation in the feet, and some erythematous maculopapular lesions over the body. I could not appreciate the eyes properly. So these are the findings that I can see. The rashes are all over body, back and abdomen.
Okay, doctor. What are the questions you would like to ask in the history? You're given an opportunity to talk to this matter.
Yeah. So in the history, I would like to ask about onset, course, duration, whether it is when did it start, and whether any fever was there or not, fever is there or not, mouth mentation, irritability, and also I would like to ask about any others like distress, breathing difficulty.
Your audio
I
is
also
bit.
like to ask about
Your audio is not that clear.
okay, it's now is it better?
Okay, fine.
Okay, so yeah, I would also like to ask about any eye involvement of the eye, involvement of the joint or rashes, whether it is coming with the fever and going with the fever. I would also like to ask about pain in joint or anywhere, bone pain. I would also like to ask about feeding and hydration status, and also any racing of heart, uh, though the child may not say, but if mother can feel.
Okay. So, what would you like to examine this side? There are an opportunity to examine this side. What did you
So
talk about?
examination wise, I would like to do the airway breathing circulation assessment. I would like to check vitals like oxygen saturation, blood pressure, hydration status, and I would also like to do a detailed head to toe examination, uh, uh, like eye examination of the hands, feet, skin, rash examination, joint examination, and also I would like to do cardiovascular examination.
Okay. So, from your observation, like video, like what are your differentials? If you think of
So
like this
my
one.
differential one is it's associated with the fever and Kawasaki disease. Then other like systemic onset when I look at arthritis and conditions like viral exanthem, viral fever with the rash, and post-COVID PINSTS. These are my
Okay.
it is.
Okay. Fine. Okay. Considering your differential of an Kawasaki disease, how do you like to manage this child?
So Kawasaki disease, the child with that's after clinical examination and history, I would like to inform my consultant, and I would like to admit the child and plan some investigations and manage. Investigation wise, I would like to do full blood count and ESR, CRP, inflammatory markers. I would also like to check for liver function test for albumin protein, and these are the investigations that I would usually like to do. And I would also like to involve multidisciplinary team involving the cardiologist to do formal echocardiography. And I would also like to consider management like fever management with antibiotics, rest, and aspirin, and to consider IVIG.
Okay. Okay. How would you like to follow this child?
Follow-up of this child will need echocardiography, and that at 4 to 6 weeks, 7 to 10 days after the starting of fever, and then at 6 weeks to decide about aspirin, course of aspirin, and to add any other anticoagulant like warfarin or not. And I would also like to follow up with the rheumatologist if it did not improve with the IVIG. And
Okay, Doctor. Are there any feedback or what is your impression?
my feedback, right? It's I think I tried to cover maybe the management portion.
Always
I
read the
don't know
guidance.
whether. Sorry, sir.
Others, you have any doubts or anything to add up on this video?
I have a comment as well as a question that while they were trying to expose the child from the front and the back, they were trying to check if there is rash or not, and whether it. I could not appreciate any rash, anyways, but they were trying to see whether it is blanchable or not blanchable, or what were they trying to do. And lymph nodes also they were trying to palpate. So he did not. It was not clear, but he could have mentioned that thing. They were doing
I
something
did
else.
not appreciate that. Actually, I did not appreciate about lymph node. But RAS, I saw that they tried to basically palpate whether it is sandpaper like, or I don't think it was, they were doing the blanchability test.
They were doing something, and some neck swell. They were trying to feel something in over the neck, maybe cervical lymphadenopathy.
So that I felt that is child's hand was there. Like, yeah, from back, maybe, yeah.
So, what are the sort of rash we get in Kawasaki disease?
Polymorphic rash.
What is the
Erythematous.
So it's a polymorphous rash, meaning it could be a macule, papule, whatever form. Usually it's not vesicular. So apart from vesicular, it could be of the polymorphous type. And regarding this, the limbs, I think you mentioned about that you found something like, I think, about desquamation, right? Desquamation is generally the part that is seen in the you see the hands here. It's the later part of the disease you get the desquamation. Generally, in the initial phase, you get more of this erythema swelling. You see the hands and foot, it is like swollen. Okay, the creases over the joints are not visible. It's swollen and there is a redness of the hand as well as in the foot also, I think. Because it's right. Yeah, hands also is red. Right? It is more of edema and erythema in the initial phase. Descommission comes in the later part. And about the differential, any skin rash, please keep drug reaction in your mind. Okay. So include those things in the history as well, and the acid history. And as you rightly asked about the duration of the illness, how it started, how it progressed, where did the rash begin, and how the child was sick, and comfortable, all those things you will ask. Setting, clearly mentioned setting as a hospital setting. Child is in structure, is being moved on, looks like a hospital setting. Okay. To start at the setting, then tell about the general examination before these, if it is possible, and then someone quickly give a comment about what we saw in the initial part of the video. If it's a long video, tell about the initial part of the video, then the middle part of the video, then the end. So you can tell about it is initially about the mouth, and then about the hands, and then they're examining the rash, and then they're looking for the nose and the neck, like that you can tell you. And apart from that, I'm telling about the investigations. Always tell investigations for the diagnosis. You will discuss with the cardiology team and arrange for an echo. That should be your initial investigation. Then supportive investigation. Initial investigation for the diagnosis and supportive investigation. That is separate your investigation, so that it will become very clear. You will not miss anything. And support investigation, when you're telling, tell about you're looking for full blood count, you're looking for anemia, you're looking for leukocytosis, you're looking for thrombocytosis, such that. So that again, you instead of just telling you will do this and that, you will tell what you're looking for actually. That will be even more better than just listing the investigations 1, 2, and 3. So that is one point. Again, management started, you will tell admitting. Okay, you did mention that in between. Okay, you clearly mentioned that if it is going to be an acute case, you will do admission, stabilization, isolation in those lines, depending upon the case. If it's a rash, if you think it's infected, then you will do isolation, all those stuff. So if it's acute case, admission, stabilization, or isolation in those lines. If it's a chronic case, a video of a chronic incident, you will tell about review of the old records and then address the current concerns. That will be your opening statement of your management. You will review the old records and old investigations, old imaging, whatever time. And then you will try to answer the current questions in place, right? Then tell about the team involvement. Then tell about, just give a preliminary opinion on the management. You will start the child and IVAG, and then depending upon the things you will say upon aspirant. Okay. And then you will repeat the echo for 2 weeks and 6 weeks. And then depending upon the case severity basis, case basis, you will do interim echo as well. And then therapy for IVAG, aspirant, those things you will add up. Supportive care and follow, counsel the mother about the severity of the problem and the need for an follow. All those things you will add up. This guidance is there. Any questions overall? The history. And if somebody is interested in joining a group, we can always contact Dr. Balaji. The number is here. They will let you know about those details and things in WhatsApp. Any doubts or quick comments? Somebody wants to say something? Add there.
So, like, how can we improve more upon communication skills?
Practice.
Hello.
And always have somebody who will be able to correct you when you practice. Okay.
Okay, sir.
So that see, there are many things which we can control even before the exams, like the points I told right now. There are a few scenarios, there are a few solid stations where you can put a questions. You should be aware of that. Unless you are very sure before the exams, you can't put that here. You will have a doubt whether can I ask or I can't ask. If you have the doubt in mind, then you will not do fluently in the exams. Similarly, for history, like how we are going to allocate your time, how we are going to unmark hidden agenda, what are the things you will think if it's an acute case, how will you manage, chronic case, how will you manage, and examination, what are the points you will tell at the time of knock, if it's an investigation, what are the things you are going to tell. All those things are already fixed. You try to have some fixed points before even you enter the session. And then there are obvious things you will change depending upon the case.
Right.
So you will always make sure that where you're going to draw. So you will see if it's information giving, you can draw outside, or even you can draw as you talk. If you think the session is going in direct information giving, obviously you will draw. Okay, that is very clear. But if it is,
sorry, sir, regarding heads, also we will ask heads history also for a teenager. For a teenager, heads also we can include, like asking, do you have any problem in school, or some upfront questions you can ask, right?
Definitely. Heads is a part of your second part of your history. After you finish your present and past, and if it's going to be a chronic case, then 7+6 scenario, heads is an important part. You will ask about menstrual history as well as heads history in adolescent, female. Definitely sure. Many times menstrual history is important. So you will definitely ask about that. Just one line. Is your cycles regular? That's all. That's right.
Doctor, can we ask him, is the puberty has started? Puberty is a jargon, or is it okay? Everybody knows about puberty.
Puberty, I think it's not a jargon, and cycles is also not a jargon. It's fine. Depending upon the age, if you think it is close to puberty age, you can ask like has she resumed her cycles? Has she started her cycles? If you think puberty is not a jargon. Either way, so puberty or cycles.
If it is a male?
Male only heads. Heads. And if you want to ask about the pubertal spread, then you can ask about the hair growth in case if you think that's relevant, very relevant. Ask about the hair growth for the face.
Okay.
Sir, actually, I was asking in terms of communication scenarios, asking heads history. If it's a teenager or some compliance issues are there, or something like that, admissions, if he's not allowing. So that way we can ask heads history up front, or we allow.
No. Heads history is generally meant for only history, not for communication. The general rule in communication is you will not ask any further information from the role player or the patient.
Okay.
Okay. If you think the for example, the child is on, for example, the adolescent wants OCP.
Right.
Okay. You think you want to ask heads history. Again, you will not ask any questions like who is your partner, or are you aware of all those things. You will tell, I want to tell about safe sex. You will start giving information rather than asking a question there.
And in terms like if there is some compliance issue with the puffs, if the child is asthma, and if she is not compliant with the puffs, so can we ask, is there something bothering you, or why have you stopped?
If you think there is a hidden agenda there, whether it is investigations or treatment or follow-up, whatever it is, there is hidden agenda. You can tell, is there is anything bothering you?
Okay.
Tell me, which I'll be able to help you. So it's sort of more of a statement rather than an open question again.
And somewhere like in anorexia nervosa patients, she's not getting like we are withholding her discharge. Then also we can ask somewhat like, is there anything that is bothering you, or?
Okay,
Sir.
I think there's a hidden agenda. That's the way you will ask. Rather than putting point blank question, ask it indirectly or say it indirectly. Is there anything bothering you or anything troubling you which you would like to address at this point so that I may be of any help to you? It is a more polite way of giving a statement rather than asking a question. That you want to help the patient or the adolescent.
Sir, one more question. Exactly from which age we start taking heads history? Somebody has written in the chat
Age
box.
11, I think 11, 12, that's right, depending upon like
11.
the female child, if it's a menstrual history, you can start from 11, 12 years and then you can just one word about cycles, those things.
Oh, heads, the entire head.
Heads, you're asking about heads, then again 13 years.
13 years. Okay.
Again, you will never ask anything directly there. You will not ask, are you in love with somebody or something like that. You will always ask, is there some special person in your life? Special
Sorry,
person can be anybody.
what did you say? Will you ask? What will you ask?
Is there any special person in your life?
What question? Why not
Special
partner?
person. Partner is very explicit open question. Rather than asking like that, you can ask in an indirect way.
Okay. Thank you.
SST, we shall discuss in some time. That's, there are some word twists here and there you can ask so that you don't sound awkward or you don't sound it very explicit, but you ask it indirectly. Many times in history, if you go near the areas wherever there is an hidden agenda, the role player will themselves will click out. They will not try to hide from you. Just like we are intention to get a history from the role play, they are also in a stress to tell out whatever they have been asked to tell you. So if you just go near those areas, then they will tell all those things. Okay, thank you. So, I'll close here. Thank you. And any doubts or anything interested, we can WhatsApp us to this number.
Thank you.
Thank
Thank you all.
Sir, good night.
Right.